showing you what is happening in both lungs. So the pink is going to be the pressure in your alveoli. The tan is your chest wall, so thoracic wall. And the blue is the pressure that's between the visceral pleura and the parietal pleura. So this is your pleural cavity pressure. So the pressure between the outside air, which is atmospheric at sea level, that's 760. That versus what is in the in the pleural cavity or intrapleural space, that is 756. So 756 minus 760 gives you, I got this. So this transmural pressure is minus 4 millimeters of mercury. This, no, this is positive. So 760 minus 756 is plus 4, and this is minus 4. So I got this reverse. So it's just the difference between the inside and outside, the really inside and the intrapleural cavity, and then intrapleural cavity and the outside of the chest wall. This is a negative pressure. It actually is truly measurable if you get a very fine probe and stick it through the chest wall into the intrapleural space without puncturing the lungs. You will get a negative reading. And it usually is around -3, -4 millimeters of mercury. The pressure here, they usually don't talk about it, but it is mathematically, it will give you a pressure of +4. This is helping to keep the visceral pleura pushing out towards the parietal pleura and keeping that space small and keeping those tissues stuck together. That negative pressure that is here, that -4, is a sucking pressure, so that when the chest wall goes out, that is actually going to start to suck the surface of the lung out with the chest wall. And that's going to be functionally important for expanding your lungs to get air into the alveoli. So the tendency for the lung is to want to collapse in. So I drew this little arrow and highlighted it to have it stand out. The elasticity of the lungs, they want to get as small as they can to get to the resting tension of that elastic tissue. But they can't, because the surface of the lung is stuck against the chest wall, held out at a bigger volume than it would be if it wasn't attached to the chest wall. We've all heard of pneumothorax. This is where you get injury to the chest wall, usually with gunshot wound, stab wound, and air gets through that hole into the pleural cavity. What happens to the lung? It is released from its attachment to the chest wall and it collapses to its minimal volume. And not functional anymore because there's a huge resistance to open all those alveoli, open again. So the attachment of the lung to the chest wall keeps the lung expanded, keeps the pressure lower in the alveoli, and then available to get gas into it should your chest wall expand or your diaphragm descend and expand the thoracic cage vertically. So if the lung wants to collapse in, that's going to aid in expiration. The chest wall actually would like to go a little bigger. It wants to expand out, but it can't expand out because the lung is fighting it. There's always this tug of war going on between the lung that wants to collapse to its minimal volume and the chest wall that would like to expand out, not too much more, maybe 2-3 inches out further. It can't do that, and the lungs can't collapse because of that attachment of the two surfaces together. But again, if you poke a hole in the chest wall and air gets in, causes a pneumothorax, the lung collapses and the chest wall springs out 2-3 more inches. So you can actually see that when a person has a pneumothorax, usually one lung, if both lungs collapse, they're dead. So no sense you worry about that, they're DOA. But if they arrive at the emergency room with a pneumothorax, one side of their chest will be a couple inches bigger than the other side. And you know they have a pneumothorax and you need to treat it. Find the wound, stitch it up. Of course, you clean it out and everything first. You stick a little tube in there to suck the air out, and then stitch that up, and you reattach the lung. So what happens when you expand volume? Gases, the particles of gases get further apart, and they're less likely to hit the chamber wall, and so pressure goes down. If you make the volume smaller, you're compressing the particles of the gas. They're hitting the wall more frequently. Pressure goes up. Pressure is based on the frequency at which particles hit the wall of the chamber, and that's the pressure that is measured in the chamber. So here we've got a piston that's pushing down on the gas and compressing it. And then we've got a pressure gauge in the chamber that's measuring pressure up at 2, whatever the units here are. So pressure is at 2. If you double the volume, then the pressure is decreased by half. If you increase the increase the volume 3 times, then the pressure goes down to 0.5. So as the volume goes up, the pressure goes down. This is an inverse relationship between pressure and volume. So we need to keep that in mind as the lung is expanding. The gas particles are getting further apart initially, and that is decreasing the pressure exerted against the inside of each alveolus. That will allow for air to come into the alveolus because we do not have a closed environment in our lungs. As long as the glottis is open, then we have we're going to have equilibration in pressure. But as air enters, we get more particles in our lungs. And so there are more particles to hit the wall, and we're going to see the pressure actually go back up. So initially, as the chest wall goes out, the pressure is going to drop, but as more gas gets in there, the pressure is going to go back up. So it will decrease, it will go negative, but it will return to its initial pressure. And when you exhale, initially the pressure is going up, compressing the gases, but if our glottis is open, the gas particles escape. So pressure will go up, but as the gas leaves, there's less particles to hit the wall, and the pressure will go back down to the initial level. We're going to show you this graph, and I swear you're going to be wondering, why is this happening? Why is the pressure going down halfway through inspiration and then up? And then why is pressure going up and halfway through expiration going down? Because we are losing or gaining gas particles. Okay, so let's look at that, and then we can come back to it again. Okay, we've got inspiration happening. We've got air going into the lungs, and a quiet inspiration is about 500 ml. But at 250 mL, the pressure starts to go back up. You're still breathing in, but the pressure is going back up. Why? Because you're introducing more gas into the lungs, more particles hitting the chest wall. Pressure gauge will go back towards the initial, which is 760. On expiration, pressure goes up. After about 250 mL comes out, then there's less gas in the lungs to hit the chest wall, and the pressure will come back to 760. What's happening across the whole chest wall into the lungs, the pressure that was in the intrapleural cavity started at 756, but as the chest wall went out, the lungs go along with it for a while, but then they get more and more antsy. They want to collapse more and more. The tug of war between the two surfaces gets bigger, and the negative pressure in the pleural space gets more negative. So you start out with 756 and a -4 intrapleural pressure, and then it drops down, gets more negative, it's going in the negative direction. So you now have a difference between the intrapleural and outside of -6. And then as you're exhaling, the pressure will come back up. Now the chest wall is coming in, the lungs are getting happier, and they're getting less antsy about being stretched so much. So they're taking some of the tension away from the surface interplate of the visceral and parietal pleura, and the pressure in the pleural cavity gets less negative, goes back to the 756 again. There's always this chest wall tug of war. The chest wall always would like to go out more, and the lungs would always like to collapse more. But they're stuck together and creating a negative pressure between the two. Extremely important for the function of the lungs, which is evidence. The evidence is that if you introduce air pressure into that pleural cavity, the lungs collapse, the chest wall go out. you have no function in your lung on that particular side with a pneumothorax.
Then chest wall damage early and lung damage late. Is that during inspiration?
I'll come back to that. Yeah. Okay, so diaphragm operating with the phrenic nerve descends, and the parietal pleural pulls the lung attachment onto the visceral pleural, pulls it down, volume goes up. External intercostals pulling the ribs closer together expands the chest laterally, increases the volume, and decreases pressure. So both are creating a change in volume. And this is going to be with Boyle's law, referred to as V2. So resting lung volume, so lung at rest, it's going to be V1. And then after inspiration, quiet inspiration, that's going to be volume 2. We have pressure at V1, it's going to be the atmospheric pressure, which is 760 units millimeters mercury. We won't know what P2 is at inspiration. We could put a pressure sensor in there, but since we know that P1 times V1 is going to be equal to P2 times V2, we don't need to have anything invasive. All we have to do is measure what V2 is, and then rearrange the equation, and that will give us pressure 2. So you need to know Boyle's law. You'll have to be calculating pressure 2 using Boyle's law from information in a table. So when pressure falls below the 756, if it falls to 754, then you have a greater difference between the inside of the chest wall. This is now 754 minus 760. This will give you a minus 6 millimeters of mercury. So you have a more negative pressure in the interpleural space, a greater stress on the two surfaces. The muscles are moving the chest wall out. The lung can do nothing about it because it's stuck to the chest wall and is going to go with the chest wall, but it's not going to like it. It's going to be pulling away from the chest wall, and that's what is creating this more negative pressure in that space. So air will move down the pressure gradient. The pressure is going to be less in the lungs because the volume is going up. So it's an inverse relationship, pressure and volume. As pressure goes up, volume goes down, and that's shown on that slide. As you increase the pressure, you go from a low pressure, you increase the pressure to 1, the volume has gone down by 1/3, you decrease it again, or increase the pressure again, and then the volume will go down even more to volume 1/2. So if you increase the volume, the pressure goes down. If you increase the pressure, the volume goes down. So it's an inverse relationship. you're not forcing air into the lung. You could do that, but you need a positive pressure machine to do that. You need something out here creating pressure and then pushing it through the airways to expand the lungs. You might get the pressure dialed up too much on the machine and actually blow out alveoli. So it's not a good idea to do that. So the better thing is to change the volume, keep the glottis open. The volume going up, the pressure drops, and air comes into the lungs. So it's actually the volume of the chest increasing that's bringing air into the lungs. It's not air getting forced in that's making the chest wall go out to the sides. So air flows into the lungs because intraalveolar pressure is decreased by the expansion of the thoracic cage. So expiration, as long as the glottis is open, turn off those muscles that expanded the thoracic cage. The diaphragm relaxes, comes back to a dome shape from a flattened shape. The external intercostals, which pull the ribs up and away from the ribs down below and expanded the cage laterally, turn those muscles off. The ribs relax and the diaphragm relaxes. The volume of the chest goes down, pressure goes up, air comes out of your glottis and then into the atmosphere. Forced expiration, forced inspiration, you call more muscles into play. For forced inspiration, you got your sternocleidomastoid, scalenes, pectoralis minor, serratus anterior, all assisting in expanding the thoracic cage. You get to a bigger volume, you can get more air into the lungs. Forced expiration, you call into play the intrathoracic, the intrathoracic muscle, and then also the abdominal muscle, and shove abdominal contents up into the diaphragm. The internal intercostals pull the ribs together, intrathoracic pulls the ribs together, volume goes down, pressure goes up, air comes out.
The lungs are also forced to enlarge. Because of Boyle's law, as lung volume increases, as the thoracic cavity enlarges during inspiration, the lungs are also forced to enlarge. Because of Boyle's law, as lung volume increases, intraalveolar pressure decreases below atmospheric pressure. Air flows down the pressure gradient into the lungs. Airflow continues until intraalveolar pressure equals atmospheric pressure. Click the expiration button to continue the cycle. During expiration, the lungs recoil to their pre-inspiratory size. As lung volume decreases, intraalveolar pressure increases above atmospheric pressure. The pressure gradient now favors the flow of air out of the alveoli into the atmosphere. Air flows outward until intraalveolar pressure equals atmospheric pressure.
Okay, so inspiration.
As the thoracic cavity enlarges during inspiration, the lungs are also forced to enlarge. Because of Boyle's law, as lung volume increases, intraalveolar pressure decreases below atmospheric pressure.
That's the first
Air flows down the pressure gradient into the lungs. Airflow continues until intraalveolar pressure equals atmospheric pressure. Click the expiration button to continue the cycle.
So as the chest wall goes out, pressure goes down, air flows in for the first half of the curve, and then the particles start exerting their random impacts on the inside of the lung. That's going to increase the pressure back to 760. So when going down to 759, and then as the air is flowing in and now bouncing off the walls, then the pressure goes back up to 760. On expiration.
During expiration, the lungs recoil to their pre-inspiratory size. As lung volume decreases, intraalveolar pressure increases above atmospheric pressure. The pressure gradient now favors the flow of air out of the alveoli into the atmosphere. Air flows outward until intraalveolar pressure equals atmospheric pressure.
So first thing that happens, the chest wall recoils, creates an increase in pressure, glottis is open, air flows out. As air is flowing out, there's fewer particles to hit the inside of the alveoli. So pressure had gone up to 761, but then it comes right back down during the second half of expiration to 760. Intraalveolar is inside the alveoli, not intrapleural, not between the two pleural. This is intraalveolar, within the lungs.
The respiratory muscles change the volume of the lungs by changing the volume of the thoracic cavity. The major inspiratory muscles are the diaphragm and the external intercostal muscles. These muscles contract during every inspiration to enlarge the thoracic cavity, with the lungs following along. The intraalveolar pressure within the alveoli, or air sacs, is 760 millimeters of mercury when equilibrated with atmospheric pressure. Lung expansion reduces the intraalveolar pressure below atmospheric pressure. Air flows in during inspiration until intraalveolar pressure equilibrates with atmospheric pressure. The accessory inspiratory muscles, located in the neck, contract only during more forceful inspiration to further enlarge the thoracic cavity. As the lungs further expand to fill the larger thoracic cavity, the intraalveolar pressure drops even further below atmospheric pressure, so that more air flows in before equilibration occurs. No muscles contract to accomplish expiration during quiet breathing. During quiet, passive expiration, the inspiratory muscles relax, and the thoracic cavity and lungs return to their pre-inspiratory size. As the lungs recoil, the intraalveolar pressure increases above atmospheric pressure, so air flows out of the lungs until equilibration occurs. The major expiratory muscles, the abdominal muscles and the internal intercostal muscles, contract only during forced or active expiration. Their contraction reduces the size of the thoracic cavity even further than during passive expiration. As the lungs subsequently decrease even further in volume, the intraalveolar pressure increases even more. Therefore, more air flows out before equilibration occurs.
Physiology is good, the anatomy is incomplete, because not just sternocleidomastoid, it's also scaling, pectoralis minor, reversing its origin and insertion, the serratus anterior, reversing its origin and insertion, so they're not acting on the scapula, they're acting on the ribs. And then expiration, they've got abdominals, they're only showing rectus, but all of the abdominals, plus the internal intercostals plus the intrathoracic muscle. So take Martini's muscle list and not this video's muscle list. Okay, so back to this slide. We've got this tug of war going on between the two pleura. During inspiration, the chest wall is winning. You want to think of it that way. It has the advantage because it's got the muscles pulling it out. The lungs have nothing to do but go along for the ride, but they will, at the end of inspiration, be more and more stretched. So as soon as you turn off those muscles for inspiration, then the elastic recoil of the lungs will then have the advantage and help you with expiration. So during the, let's see. So chest wall advantage is early for chest wall. How did I write this? Okay, so the chest wall has the advantage going out early in inspiration. The lung is getting more and more stretched and wants to come in more and more during late inspiration. That also is helping to reverse the pressure. A lot of it is just due to the fact that more air is coming into the lungs and hitting the walls. That's putting this pressure curve on the way back up to 760. But also this late advantage of the lungs really having more of a tendency to want to collapse inwards will help to also increase that pressure back to 760. This on expiration, the lung collapsing in is giving an advantage to expiration. But as the chest wall is getting smaller and smaller, it's going to want to go back out and expand again. Even though the muscles aren't helping it, it has a tendency to always want to go back out. So that later in the last half of expiration is going to help with bringing the curve back from 761 to 760. So you've got two things that are helping to reverse these pressure curves here. Most of it is the gas that's moving in and out of the lungs. But you always have this tug of war between the two surfaces that are going to get greater. The greater the chest wall, the more the chest wall goes out, the greater the tendency that the lungs have to want to collapse in. When on expiration, the lungs are happy, they're going in the direction they want to go, but during the last half of expiration, the chest wall is now getting irritated, it wants to go back out, and that tendency is going to aid with the gas leaving the lungs and bringing the curve back to 760. Airway resistance, it's like resistance to blood flow or flow through any tube, a hose, or a pipe. You're going to have Poiseuille's law involved. You're going to have 8 times the viscosity of whatever. This is viscosity of air. So it's pretty small, but as you get more humid or more particles in the air, then the viscosity is going to go up. Length of the airway matters. The pi is a constant, so again, radius to the 4th power. The more you branch your airways, the smaller they get. the more resistance there is for the air to flow through those smaller airways. Airways can be further constricted by chemicals that are released by cells in the airways. So we've got histamine, we've got O2 concentrations, we've got CO2 acting to actually increase the radius. We've got various things that can influence the radius of the airways beyond their normal resting levels. Viscosity in this town is changing a lot with a lot of the low pressure systems that come in, and also bringing fog up from the South Island. We're going to have an increase in viscosity. And so the air gets thicker due to water vapor, and it also gets thicker due to particulate matter. And then those particulates, if you're sensitive to them, they set off the chemical release that can cause your airways to get smaller. You can get an allergic reaction to the sulfur and other particulates. Bronchoconstriction is going to increase the resistance for airflow. Could be so bad that you actually need medication to help to counteract that. Bronchodilation is usually going to be aided by the sympathetic nervous system and the chemical it releases, which is epinephrine, and also the CO2 production by your metabolically active tissue. The more exercise you do, the more CO2 that's produced by your skeletal muscles, the more CO2 comes to your lungs and gets into your alveoli, the wider your airways get so that you can get that CO2 out, which benefits O2 to come in through those big wide open airways. During rest and repose, parasympathetic takes over and airways constrict. But when you're resting, there is no need for high O2 to get into your lungs. So it's a functional constriction, meaning you're just limiting airflow based on the needs and metabolic demands of the tissue. So bronchoconstriction, the airway radius goes down. Radius to the fourth power, radius is always the greatest determinant of airway resistance. As radius goes down, resistance will go up. Radius is in the denominator, so inversely proportional to resistance. Pathological factors that influence airway bronchoconstriction, we've got our slow reactive substance of anaphylaxis, several chemicals released by cells that are called leukotrienes, and then also histamine, which is not a leukotriene, but is also going to stimulate the constriction of smooth muscle. So anything that you're allergic to will increase this SRS-A, slow reactive substance of anaphylaxis, and histamine released from your mast cells and basophils. Along with allergens, you tend to get extra mucus into your airways. To try and trap those allergens and get the respiratory escalator to get them out of your lungs to stop the irritation. It also is going to create a physical block to your airways. So you've got chemicals that are constricting the airways, but now you've got more mucus in the airways. So you've got a double whammy going against you to decrease the airflow into the lungs. Histamine makes the blood vessels in the area more leaky to fluid. Now you've got fluids going into the airways, and that is going to also increase the resistance to airflow going through. Airways may collapse. This is extreme case of pathological factor. Airways can collapse if there is excessive pressure on them. We'll see later in the chapter. This normally occurs when you are at very, very low lung volume. When you're blowing out the birthday candle, and then you can't blow out anymore because your airways have collapsed at the end of your exhalation. But pathologically, you can decrease that tethering effect. You lose alveoli due to chronic infections that are going on in your lungs. Your macrophages and other phagocytes that are phagocytosing these allergens are releasing chemicals. We'll learn about that later on. They're proteases primarily, and they're breaking down alveolar walls. The alveoli disappear, the ability for them to hold the airways open is less. So with minor exhalation, airways can collapse. So you lose the tethering, airways collapse earlier and start to trap air in the lungs. And this old cruddy air never gets out of the lungs. Parasympathetic will cause bronchoconstriction, but that is related to the metabolic demands of the tissues and the type of activity your body's in at the time, which is rest and digestion. So it's due to lack of demand by the tissues and a decrease in CO2 because the tissues are not metabolically active. So a decrease in CO2 will give you bronchoconstriction. Dilation, increased CO2 is the primary regulator of the bronchodilation. To meet the metabolic demands of getting rid of the CO2 that the tissue are producing, and as a result, increasing the O2 getting in, which the tissues are also demanding that be brought to them. Pathological factors for bronchodilation, as far as we know, there are no pathological reasons for bronchodilation. The physiologic control factors, sympathetic nervous system, fight or flight. You need to get ready for the fact that O2 demand is going to go up. So dilate the airways when you're recruiting the skeletal muscles and shifting blood flow, and then you'll be ready to meet the metabolic demands. Sympathetic nervous system releases epinephrine. Epinephrine will eventually get to all these receptors, and the nervous system can back off and relax because epinephrine is stimulating the receptors that the nervous system would be, its neurotransmitters would be stimulating. So long-term, epinephrine takes over for the nervous system. So COPD, chronic obstructive pulmonary disease. This is a pathology. This is what is causing problems with your airways. So COPD, the first term is chronic. So it means it's not just happening this minute, this hour, today. It's happening every day for a long period of time. The three main problems that contribute to COPD, first one is chronic bronchitis. Well, we all get bronchitis sometimes when we get a virus or of some kind or a bacterial infection, but our immune system handles it, and in 7 days everything is cleared out and the bronchitis goes away. Sometimes it lingers on a little bit because some of those pathogens hide out down in your airways and they're still irritating. So the bronchitis might be lingering, but usually it's on the controlled side. So what happens with chronic bronchitis, you have more mucus in your airways. That obstructs airflow, so it's harder to breathe. The itis part is inflammation, so we've got histamine involved. Histamine is going to cause smooth muscles to constrict, and it's also going to cause blood vessels to become more leaky. So we're going to get edema, and we're going to get the mucus obstructing the airways, plus constriction of smooth muscle. That's the problem. When it's long-term and it's not going away, you need, with the immune system handling it, then you need secondary treatment. And it might involve steroids, it might involve other kinds of medications to treat that. Asthma, we've got some allergen that is causing our airways to react by releasing histamine, causing increase in mucus, causing increase in fluid, and causing smooth muscles to constrict. A typical one that is involved is chlamydia pneumoniae. And this one, it gets down into our lungs and triggers a lot of people's asthma attacks. The emphysema, this is where you have inhaled particulates, maybe because of smoking, other kinds of things, have come into your lungs and set off your macrophages and other phagocytes, and they're releasing this chemical called alpha-1 antitrypsin. They're releasing trypsin, and normally our lungs have this alpha-1 antitrypsin to counteract what the macrophages are releasing. So it neutralizes the trypsin and protects our alveoli. If you're genetically born without the alpha-1 antitrypsin, your lungs just start to become, the alveoli start to break down very, very young. When you smoke, when you have other particulate matters that come into the lungs, you lose the ability for the lungs to produce this alpha-1 antitrypsin, and then the trypsin that's released by the macrophages is not neutralized and starts to break down the alveolar walls. That creates a lack of tethering. You don't have the elastic tissue opening your airways up, so with minor exhalation, they close down, and air is trapped in your alveoli. That air is going to be full of the particulate matter that set off the macrophages. The macrophages are there still trying to clean it up, but they're releasing proteases as they do it, and more alveolar damage is done. Eventually, you get a lot of old, stale air being trapped in the lungs and never coming out, and also a decrease in ability to get new air in because this old air isn't coming out, and that old air is pressure that the new air has to fight against to get into the lungs. So old air is full of CO2, and so less O2 is getting into your blood vessels, and you're going to start to look cyanotic. You're going to have blue tinge because you don't have all this oxygen on the hemoglobin anymore. So emphysema, they're usually in need of supplemental oxygen. Little higher O2 content in air coming in, so there's an advantage to O2 getting into the alveoli and then to the hemoglobin to be transported out to the tissues. You have a situation where you sounds like a good thing, you have more air in your lungs, but this air is old, worn out, no O2 content, probably also high in bacteria and other things that are not helping with the health of the alveolar tissue. So less O2 in this old air and therefore less gas exchange. So it's a very severe problem when it develops. Most common reason is smoking. So if you smoke, stop. Compliance is like the bubble gum. The more you chew it, the more it gets soft, the easier it is with very low pressure to blow big bubbles. Or the balloon, the more you stretch it, the less air pressure it takes to blow the balloon up. So compliance means the stretchability of the tissue with very little work or effort put into it. So low forces, great change in volume. That's compliance. When you lose compliance, you are getting a tissue that is harder to stretch. You have to work harder, put more force into it to get the same change in volume. And you lose a lot of compliance, then the whole volume expansion just starts to be compromised. You never are able to get the full volume in and out of your lungs again. So minimal effort, getting a lot of stretch, that's a compliant tissue. Less compliant lungs, you're going to have to work harder to breathe. So you're going to see people, instead of sitting there and just quietly breathing, you're going to see them sitting there and going, they're actually having to call in their accessory muscles to get the 500 ml in and out of their lungs. So fibroblasts, irritated by something coming into the lungs, creating more connective tissue, more collagen, not elastin, is what fibroblasts put out at the highest level, and this is less stretchable. That's the stuff that ligaments and tendons are made out of, not normal lung tissue. Those are tissues, the collagen fibers are resisting stretch. The asbestos, usually we don't have a problem unless you get into an old building or you're in the business of renovating old buildings, then you don't come usually in contact with asbestos anymore. Sometimes in theaters, curtains, the fire curtain to stop any backstage or offstage fire from getting across that barrier, that had asbestos in it. And ceilings also to prevent fire spreading from one floor to the other had asbestos in it. But that's not supposed to be around anymore. It is, but it's not supposed to be around anymore. Automobile fumes, smoking, all of those will trigger the fibroblasts to produce more of the connective tissue. In these diseases, asbestosis, smoking, and fumes from things like automobiles, so mechanics breathing a lot of fumes on a regular basis. They start out as a fibrotic disease, but as the macrophages get involved inside the alveoli, then the alveolar walls start to break down, and you end up with an obstructive problem where when you try to exhale, the airways close because of the lack of tethering. So it starts out as a fibrotic problem. You're going to lose your vital capacity. You're going to increase your residual volume in the early part of the disease, which is bad enough. But then in the later disease, when you try to exhale, airways close down and trap the old air in the lungs. So elastic recoil, That's the fight that's going on. Normal lungs want to collapse. The more you stretch them, the more they want to collapse. Turn off the force that expands the rib cage, diaphragm, or external intercostals, and the lungs recoiling will help to increase the pressure for exhalation. The ability to get air into your alveoli is dependent on the surfactant being there. If there's no surfactant there, your alveoli will collapse and your airways will collapse. The smaller airways will collapse. There is always some alveolar surface tension, but all alveoli should have the same surface tension. And it should be minimal so that it keeps the lungs able to expand with very little effort. So if alveolar surface tension goes up because surfactant is disappearing, it's not being made, or it's gotten washed out because you got fluids into your lungs. So another danger of pneumonia, which is bacterial and viral, but also fluids getting in there. So you've got a combination of problems going on with pneumonia. But fluids collecting in the alveoli will wash away the surfactant. And when you exhale, alveoli tend to collapse. Healthy lungs, you keep the surface tension at a minimum. You got this thin fluid of surfactant lining your alveoli, pushing water molecules apart, keeping that surface tension low, and then with very little effort, you get fluid into the lungs. All right, so went over that.